You are listening to the American College of Cardiology's CardiaCast. Today's discussion is the first part of a series of educational activities that include 4 CardiaCasts on the evaluation and management of ATTR-CM. This series is brought to you by the American College of Cardiology Foundation and MedIQ and is supported by an educational grant from BridgeBio. This is the first of 4 podcasts in this educational series. Keep an eye out for more engaging discussions on ATTR-CM coming soon. For additional complimentary CME and resources on this topic, visit www.med-iq.com or acc.org. I'm Dr. Michelle Kittleson at Cedars-Sinai in Los Angeles, California, and I am delighted to be joined by an amyloid expert, Dr. Jan Griffin from the Medical University of South Carolina. We're going to talk about clinical clues, diagnosis, treatment, future directions, so I'm going to dive in. Jan, thank you so much for being here.
Thank you for having me, Michelle. It's a pleasure.
So let's start with what clinicians need to know almost more than anything else. What are the cardiac findings that for you, when a patient walks into your office, may suggest a diagnosis of ATTR-CM?
So typically when patients come into clinic, they will express a history of significant fatigue. Often they will have had heart failure symptoms or a family history of heart failure. Generally, on ECG, you may see conduction system disease, atrial fibrillation or flutter, low voltage to LV mass ratio, or even a pseudo-infarct pattern. On echocardiogram, which is a very useful initial screening tool, but not diagnostic for ATTR cardiomyopathy, clinical clues can include increased LV or RV wall thickness, interatrial septal or diffuse valve thickening, pericardial effusion, biatrial enlargement, and they will generally have a preserved ejection fraction with low stroke volume index. However, I will say that as patients progress, their ejection fraction does tend to decrease with time. On Doppler imaging, you may see reduced tissue Doppler, so reduced S', E', and A' velocities, reduced TAPSE. And then looking at global longitudinal strain, there will often be an apical sparing pattern with this classic cherry on top appearance. Cardiac biomarkers may provide a clinical clue, and they can help to exclude ATTR cardiomyopathy in patients for whom you have a low clinical suspicion.
I think that's such a wonderful overview. The patient walks into your office, fatigue, dyspnea, edema. The good news is pretty much any cardiologist, internist, is going to order an ECG and an echocardiogram in that clinical picture. And you've given us a perfect assessment of what you'd highlight. What are the classic findings on the ECG, echocardiogram, and who doesn't get biomarkers these days? So that's very helpful. But the lovely thing about ATTR-CM, from a clinical clues perspective, is that the amyloid doesn't just go to the heart, it goes other places as well. So tell me, how common are these extracardiac symptoms and what extracardiac manifestations may raise your clinical suspicion for ATTR-CM?
Yes, extracardiac signs and symptoms are common in these patients. ATTR is seen in about 8 to 16% of patients with severe calcific AS undergoing TAVR, and about 15% of patients over 60 years who are hospitalized for HFpEF. But outside of the heart, deposition in the soft tissues often precedes cardiac involvement. About 80% of patients have preceding interventions for joint replacement surgery, carpal tunnel syndrome, biceps tendon rupture, or even trigger finger release. Spontaneous biceps tendon rupture can occur about 5 years prior to the onset of heart failure, and carpal tunnel surgery can manifest 5 to 10 years prior to cardiac diagnosis. In addition, peripheral and autonomic neuropathy is a feature of many of the TTR variants. It's seen in about 80% of patients with V50M, which is endemic in Portugal and Japan and Sweden, and about 10% of patients with V142I experience polyneuropathy.
I'm so glad you mentioned the V142I because that's quite common in some Americans. Is that correct?
That is absolutely correct. About 3.5% of Black Americans carry this variant.
So this is so interesting. And that's what makes medicine a wonderful profession, is that we're always refining our diagnostic acumen. If a patient walked into my office 10 years ago and said, I'm fatigued and short of breath, and I have atrial fibrillation and severe aortic stenosis, and my echo has some thick walls that doesn't really match my electrocardiogram. Oh, and yeah, I had bilateral carpal tunnel surgery 10 years ago. I'll be like, why are you telling me about your carpal tunnels? I don't care about your carpal tunnels. But now we've realized that these seemingly disparate findings can lead to a satisfying, unifying diagnosis. So it's so important to incorporate new medical knowledge to hone your pattern recognition for these patients. That's a phenomenal overview. So that's the first hurdle, because if you don't think about it, you won't look for it. So let's talk about, once you think about ATTR-CM and once you want to look for ATTR-CM, how do we diagnose it? So please tell us the diagnostic algorithm for ATTR-CM, and in your vast clinical experience, what are the common pitfalls?
First, I'll say that there are many published algorithms out there in the literature. So I would urge practitioners to find one that they're comfortable with, pick one, and follow that to help with the diagnostic process. I will have to say that the most important initial step is to exclude light chain or AL amyloidosis. This is essentially a medical emergency and needs to be treated urgently in patients. So this must be ruled out before any further steps are taken. In order to rule out AL amyloidosis, you have to perform serum free light chain analysis and serum and urine electrophoresis with immunofixation. The combination of these three tests has a 99% sensitivity for the detection of AL amyloidosis. So when AL amyloidosis has been ruled out, with a negative monoclonal protein screen and normal free light chain ratio, you can proceed with radionuclide scintigraphy. And this can be used for the non-invasive diagnosis of ATTR cardiomyopathy. It is important to ensure that both planar and SPECT or SPECT-CT is performed in order to assess for false positive results, which can occur due to blood pool. Patients with grade 2 or 3 uptake, which is confirmed on SPECT or SPECT-CT, have a 100% positive predictive value for the diagnosis of ATTR cardiomyopathy in the absence of a monoclonal protein. If, on the other hand, the patient has abnormal monoclonal protein screen or abnormal free light chain ratio, they must undergo tissue biopsy and amyloid typing by mass spectrometry. As for the pitfalls, there are many common pitfalls that a clinician may come across when making a diagnosis of ATTR cardiomyopathy. Firstly, in patients who have an abnormal monoclonal protein screen, the site of biopsy is very important, and sensitivity varies depending on the site of biopsy. So, for example, the sensitivity of a fat pad biopsy for the diagnosis of wild-type ATTR is only about 14 to 16%, and the sensitivity of a bone marrow biopsy is only about 30 to 38%. The sensitivity of a fat pad biopsy for the diagnosis of AL amyloidosis is slightly higher. It's 73 to 84%, and a bone marrow sensitivity is only about 60%. So although these are helpful if they're positive, a negative biopsy neither excludes AL nor ATTR amyloidosis. So as a result, I feel it is often best to target the affected organ, which in our case is generally the heart. Secondly, when considering nuclear scintigraphy, it is essential that uptake on planar imaging is confirmed using SPECT or SPECT-CT, as I've already mentioned, and this should be done at about 2 or 3 hours after radiotracer injection. This is because blood pool activity can cause false positive read on planar imaging alone. Other causes of false positive scans can include previous myocardial infarction, rib fractures overlying the heart, hydroxychloroquine or plaquenil toxicity, and of course AL amyloidosis. On the other hand, false negative scans can occur with certain ATTR variants such as phenylalanine 84-leucine and valine 50-methionine, or even in the early stages of disease itself.
That was an incredible overview. So I think if you have an abnormal monoclonal protein screen, do not pass go, do not collect 200. Tissue is the issue, biopsy something. You might start with a surrogate site. You will end with the heart to exclude it, because we cardiologists aren't so dramatic, but if there's anything that's going to kill you quickly, it's heart failure with AL amyloidosis. So I agree that's never a diagnosis you want to sleep on and miss. And if you just ordered your radionuclide scintigraphy because you said, that monoclonal stuff is too complicated, 10 to 20% of AL can have a false positive. You will miss the diagnosis and kill the patient. That is such a perfect overview of the pitfalls. And you are too kind not to recommend an algorithm, but Dr. Griffin and I were both authors on the 2025 ACC Concise Clinical Guidance on cardiac amyloidosis, and that has a beautiful algorithm, so everyone should check that out. But there are a bit of other subtleties to the diagnosis. There are patients who present in different ways. They don't walk into your office with heart failure symptoms. How do you approach the patient who presents with extracardiac evidence of ATTR-CM? Because now there's a heightened awareness. So they got their carpal tunnel surgery and their savvy surgeon sent it to the pathologist, and now they have ATTR in their carpal tunnel, and now they're sent to you. What do you do for that patient?
So that is not uncommon to find. So there's no evidence, though, that these individuals with extracardiac evidence of ATTR deposition derive any benefit from the currently available disease-modifying therapies. But we do know that they have a greater chance of developing ATTR cardiomyopathy. So I tend to treat them similarly to the asymptomatic TTR variant patient. For these patients, consensus documents recommend assessment in asymptomatic gene carriers approximately 10 years before the age of onset in the proband. So this screening includes a thorough history and physical examination, asking about all of the clinical clues that we've already mentioned, electrocardiogram, biomarkers, and an echocardiogram, and if possible, performing this with strain imaging. If there are any abnormalities detected on the screening, then pursuing additional diagnostic testing, as I've already outlined, is recommended and should be pursued. If the variant is associated with polyneuropathy, neurology consultation should be considered. And if there is no clinical evidence of TTR amyloidosis detected, repeat testing is reasonable about every 3 to 5 years or sooner if the patient starts to develop symptoms.
I think that's perfect. You don't necessarily need to send everyone for a radionuclide scintigraphy scan. That's not only resource intensive, but it involves exposure that they may not need. But if you start with more minimal, because the biomarkers, ECG and echo, will be very sensitive to pick up involvement, even perhaps before the patient is highly symptomatic. I think that approach is beautiful. And now that's a really lovely overview on diagnosis. So we passed the first hurdle. We thought about it because we thought about all the clinical clues, both cardiac and extracardiac. Then we passed the second challenge, which is diagnosis, order the right tests, interpret them in the right sequence. And now let's move on to the third challenge, which is treatment. So tell us about the current therapeutic landscape of disease-modifying therapies for ATTR-CM.
Sure. So currently, there are 2 types of disease-modifying therapy commercially available. TTR stabilizers and TTR silencers are knockdown agents. The 2 TTR stabilizers available are tafamidis and acoramidis. Both of these are oral preparations. They work by stabilizing the normal tetrameric structure of transthyretin to prevent dissociation, misfolding, and aggregation into amyloid fibrils. Silencers, on the other hand, cause degradation of TTR messenger RNA in the liver, in the hepatocytes, thereby reducing TTR production. So vutrisiran was approved for ATTR cardiomyopathy in 2025. It is a subcutaneous injection given once every 3 months. But it is important to note that patients on silencer therapy must also take a supplement containing the recommended daily allowance of vitamin A. Another silencer therapy called eplontersen is currently only approved for patients with variant ATTR polyneuropathy with or without cardiac involvement, but we are awaiting the results of the CardioTransform study, which is investigating the use of eplontersen in ATTR cardiomyopathy.
So this is very exciting. If this CardiaCast occurred 10 years ago, we would have had nothing to say. If it occurred 5 years ago, we would have only had one medication to talk about. But now there, as you beautifully outlined, there are 3. We have 2 stabilizers, tafamidis, acoramidis. We have 1 silencer, vutrisiran. So in this embarrassment of riches, when a patient walks into your office and you make the correct diagnosis, how do you decide among available disease-modifying therapies for ATTR-CM?
Well, unfortunately, there isn't really an easy answer to that question. At present, there are no randomized clinical trials or comparative effectiveness studies that provide evidence that one therapy is superior to another. So we're unable to compare between the landmark trials for tafamidis, acoramidis, and vutrisiran because they enrolled different patient populations. The more recent studies enrolled patients at an earlier disease stage, and as such, they had a lower placebo event rate. So as a result, when I am discussing with my patient, the main factors that we talk about are the cost of the agent, access based on payer preferences, and then more importantly, individual preference regarding route and frequency of administration. The only caveat to this is that when patients have variant ATTR polyneuropathy with cardiomyopathy, in these patients, silencer therapies may be preferable based on clinical trial data from Helios-A and Neurotransform showing benefits in patients with ATTR polyneuropathy.
I think it's always so fascinating as medicine progresses and as advances crop up, how to decide among these therapies. And I think exactly as you noted, we know they all work. How amazing. Preserve quality of life, decrease hospitalizations, increase survival. None will make you feel better. They don't reverse disease, plug for early diagnosis, but they will all prevent you from feeling worse. So this is a wonderful place to be in. But it is that difficult decision about which one should you pick. And I think that algorithm, also in Dr. Griffin and my document, the 2025 Concise Clinical Guidance, is exactly as you said. If you've got the variant form with neuropathy, well, gosh, why don't you pick something that works for both? And if you have the not variant form, no neuropathy, then exactly, it comes down to that beautiful shared decision-making discussion, which is why AI will never replace us. Tell me what you do about the patient that says, well, I want both. Give me it all. Give me a stabilizer and a silencer. How do you approach that conversation?
Well, in that situation, again, we really have no evidence to suggest that combination therapy is superior to single agent disease modifying therapies. So typically I will tell the patient that I will have this similar conversation with the patient about agent choice and educate them on the fact that dual therapy is not superior that we know of to date, and that it is just more costly to the payer or the patient.
I agree. It is fascinating. The differences in philosophies. If it ain't broke, don't fix it. Or versus I want what I want because I want it and more has to be better. And also tackling the difference between absence of harm and evidence of benefit, which are two different bars, and balancing patient preference with healthcare economics. It's a microcosm, honestly, of our healthcare system in general. But I, similarly to you, will not advocate for disease stabilizer plus silencer therapy. If the patient says, well, if you don't give it to me, I'll get it from someone else because there really is no harm. Do I prescribe it? Yes, but I do warn them I don't agree with this approach. And I suspect, and this is actually starting to happen now, insurance companies will not allow both because of absence of benefits. And you know what? They're right. So I'm warning you, this will not likely be sustainable. It's a beautiful way of how we approach these shared decision-making discussions with patients. And in a way, these medicines are pretty easy in the sense that they don't have side effects, tons of interactions, but there are a few drug-drug interactions that we should be aware of. You already mentioned the need for vitamin A supplementation when patients are on vutrisiran, because if you silence TTR production, TTR actually transports a vitamin A around the body, so you need to give a little more vitamin A. You don't want them to get night blindness down the line. But anything else, for example, with tafamidis, any interactions you are aware of?
There is. More recently, an interaction has come up with tafamidis, and the only issue is that in patients who are on rosuvastatin or atorvastatin for the treatment of cholesterol, so the maximum dose of rosuvastatin that should be used is 20 milligrams, and the maximum dose of atorvastatin that should be used is 40 milligrams. And this is due to the risk of rhabdomyolysis when used in combination with tafamidis. If you stay within those limits, there should be no additional risk.
Amazing. So honestly, these medicines aren't rocket science. Thank goodness. Very easy to prescribe, well tolerated to administer, but the key is to watch out for those interactions. But these patients have heart failure. We all know about heart failure guideline-directed medical therapy. Is it unique? What's your approach to standard heart failure GDMT in patients with ATTR-CM?
So again, we are lacking randomized clinical data on the use of standard heart failure guideline-directed medical therapy in patients with ATTR cardiomyopathy. Patients with ATTR cardiomyopathy have generally a restrictive physiology, and so there is a dependence on heart rate to maintain cardiac output. These patients generally have a fixed stroke volume. So as a result, the use of beta blockers has historically raised concern, but observational data do remain mixed. There is one study that suggests that low-dose beta blockers, and this was the equivalent of less than or equal to 2.5 milligrams of bisoprolol, may be beneficial in individuals with an ejection fraction of less than or equal to 40%. However, I would caution that there should be a low threshold to discontinue beta blockade. Retrospective observational studies also suggest no clinical benefit with vasodilating angiotensin-converting enzyme inhibitors or angiotensin receptor blockers, regardless of the ejection fraction, with a high discontinuation rate in the studies published. They may be used cautiously, however, they're often, in my experience, not well tolerated, mainly due to symptomatic orthostasis, and some patients will also develop acute kidney injury. Most commonly used guideline-directed medical therapy are mineralocorticoid receptor antagonists and SGLT2 inhibitors. Both of these are thought to provide clinical benefit in individuals with ATTR cardiomyopathy with a low discontinuation rate.
I think your approach to standard heart failure, GDMT, and ATTR-CM is awesome because, again, as clinicians, we have to be aware of nuance and the effect of pathophysiology on the benefits of the therapies we give patients. And much like HFpEF, amyloidosis, there's restrictive physiology. And if you have that fixed stroke volume, you need your heart rate to maintain your cardiac output. Beta blockers, patients often do not like them, and they think you're the best doctor in the world when they come to you for the first time and you de-prescribe the beta blocker and their energy goes up. So I think that's a really satisfying thing to do, de-prescribe beta blockers unless you really need it for rate control of AFib and then the minimal dose. And those vasodilators, unlike HFrEF, where your stroke volume will go up in response to afterload reduction, these guys with their fixed stroke volume, nothing good is going to happen, just hypotension and tachycardia as they attempt to maintain their blood pressure in response to vasodilation. But just like you, I've noticed quite impressive improvement in symptomatic congestion, relief of congestion with SGLT2s and MRAs. So we think differently in restrictive physiology. And I think that's such an important point and a nuance that even though you want the best intentions, and we all know GDMT is so important, to apply it differently in the setting of restrictive physiology and ATTR-CM. So first hurdle, think of the diagnosis. Second, order the right tests, interpret them in the right way. Third, choose the right therapies with a good shared decision-making discussion with your patient. Finally, let's move on to future directions. It's a tough question, but how do you decide, is there evidence to help us when a patient is too advanced to benefit from current disease-modifying therapy? Because we know none of these reverse disease, they just slow progression. What's your threshold or cutoff in that situation?
Yes, that is a very tough question. And when patients come in who are very advanced, of course you want to treat them all, regardless of how sick they are. But unfortunately, we do not have data on the use of the currently available disease-modifying therapies in individuals with advanced heart failure and advanced heart failure symptoms. Examples that we may see in these patients may be very high natriuretic peptide levels, so a very high NT-proBNP, worsening or severe kidney failure, or significant functional impairment. Initiating these patients on disease-modifying therapy, of course, may not harm them, but it also may not provide any benefit to them or prolong their life. And so in such patients, consideration should be given to referral for heart transplantation or palliative care, depending on the patient and what their comorbidities and age are, of course. These patients do not tend to do well with left ventricular assist device, so durable LVADs, because they have a small LV cavity, and so the LVAD is often not the right choice for them, in addition to which many of them have right ventricular failure, which may not withstand implantation of an LVAD.
It's such an important discussion to have, isn't it? It's harder to say no than it is to say yes, but sometimes the right answer is an honest discussion about prognosis and managing expectations as opposed to false hope of a therapy that the patient is not going to benefit from. And the next unmet need or unanswered question is you put the patient on the medication, whatever one you've chosen in your excellent discussion. And I'm sure this has happened to you as often as it's happened to me. The patient comes back and says, how do I know it's working? How do you address that question?
That is a very common question that I get. And unfortunately, at present, there's really no means of assessing response to therapy, but there are several surrogate metrics that we can follow serially to provide an indication of therapeutic efficacy or disease progression. Oftentimes, I will just simply tell my patient, if you're on a stable loop diuretic dose or maybe not needing a loop diuretic, if you're not having heart failure hospitalizations, if you're not very limited in your activities of daily living, then you're doing well and we're on the right track. But some of the things that we can measure, we can follow biomarkers, again, high sensitivity troponin and NT-proBNP. We can watch the kidney function with EGFR, and we can check prealbumin serially, maybe every 6 months or every year. I tend to check them every 6 months. Functional markers such as a 6-minute walk test distance or even cardiopulmonary exercise testing, and quality of life markers such as the Kansas City Cardiomyopathy Questionnaire can also be performed at intervals every 6 to 12 months to assess for stability of disease. But this is really an area of active interest and investigation within the amyloid community at present.
So I love a point counterpoint. So yes, there is some evidence to indicate that your NT-proBNP, your TTR level or prealbumin, your 6-minute walk, these things may be prognostic. However, what am I supposed to do with that information? So I take a radical approach of never checking a test that I can't do anything about the information. So similar to you, I tell patients, you're going to feel worse over time because that's life and aging. You're doing everything you can to slow your progression because you're on the right medicine, but it's completely unsatisfying. I can't tell you how much you're responding if you're this percent responder. And you know what? When you start to feel worse, that's not if, it's when. And maybe you'll start feeling worse because you're getting old. And maybe you'll start feeling worse because of the amyloid progressing. We can't really tell the difference. I can't do anything about it anyway. So take your meds and enjoy each day. And no, I'm not checking any of those other tests. But that's what makes medicine an art. There's a spectrum here of what is reasonable to do in the absence of evidence. So last unmet need, future direction. Tell us about future therapies. Tell us about gene editing, TTR depleters. Where are we? What excites you most?
Absolutely. Gene editing with CRISPR-Cas9 is currently being investigated for the treatment of ATTR cardiomyopathy, and this is in the MAGNITUDE trial. Now, this treatment is a single dose administration, and phase 2 studies showed a knockdown effect of 89% at 12 months. And to put that into perspective, that's a little more than the silencer therapies that we have available currently, vutrisiran and eplontersen, which are around the 80% mark. Unfortunately, the phase 3 trial is currently paused, but we are hoping that it will be up and running again in the near future. In my opinion, the most exciting development is the potential to reverse the disease process. So the stabilizer and silencer therapies that we have already discussed merely slow down disease progression. They do not reverse it and they do not stop disease progression. So patients obtaining these agents or receiving these agents will continue to progress, albeit at a much slower rate than patients who are not provided with these therapies. So the potential to reverse the disease process is currently being investigated using depleting agents, and these are monoclonal antibodies. They recognize misfolded transthyretin, and they facilitate degradation by activating a macrophage clearing mechanism. One study, phase 3, is already fully enrolled, and we are hoping that there will be another study, a phase 3 study up and coming, hopefully later this year, to investigate a second depleting agent.
I think this is super exciting. The future, gene editing, TTR depleters. I mean, personally, gene editing is not so exciting to me. I mean, what's a gene editor except a super permanent silencer? And we already know silencers like vutrisiran work. But I, like you, are fascinated by the idea of the depleters that will suck the amyloid fibrils out of tissues more scientifically than that. But the key, I think the gazillion-dollar question, probably literally gazillion-dollar question, is going to be what happens when you suck the amyloid out of the tissues? Will the heart snap back like a rubber band and be perfectly normal? Or will it still have the scars of the prior amyloid deposition? I suppose if we think about AL, you have a hematologic response, you get rid of those horrible toxic light chains, and you can have organ response, improvement in cardiac function within the next 9 months or so. I suppose the hope is we could see something similar for ATTRs. So the future is bright. Dr. Griffin, Jan, I cannot thank you enough for your outstanding expertise, perspective, and clinical pearls. Thank you for being here.
Absolutely my pleasure. Thank you for having me.
And thanks to all of you out there for joining us today. As I mentioned in the beginning, this activity is part of an educational series provided by the American College of Cardiology Foundation and MedIQ and supported by an educational grant from Bridge Bio. This is the first of 4 podcasts in this educational series. Keep an eye out for more engaging discussions on ATTR-CM coming soon. For additional complimentary CME and resources on this topic, visit www.med-iq.com or acc.org. Thanks so much.